Hello, everyone. After several years, we are at long last in a position to tell you about the outcomes of this study on DSD models, still for HIV, but in another context, since it is in Carnot, in central in CAR. Now, there's still this epidemic in Central and Western Africa, neglected by funding and policies due to lower HIV prevalence versus other regions. In CAR, it's one of the highest in Central Africa, and political instability and also the vulnerability of the health system have weakened strategies to fight HIV, and the cascade of care is full of loopholes. There are some efforts to improve retention in care is still needed. Since 2009, MSF has been cooperating with MOH in Carnot. Prevalence is estimated at 5%. Carnot Hospital is the only health district center where patients can be screened and started on treatment. This is done in the follow-up clinic with a comprehensive, free and integrated care for patients on an OPD basis. And for HIV, according to the national program, DSD models are used. As we were told by Gian, these DSD models, in fact, encourage retention in care because it's based on their preferences, but then, of course, provided they are stable from the clinical point of view and adhere to treatment. Now, in Carnot, we started in 2018. The patients goes to the hospital twice every 3 months, and so that there's a fast-track refill, and so that the community-based group can also get their ART. That's another possibility, and decentralized sites are available since 2016. 558 patients are grouped in 122 CAGs. However, the dynamic for their creation changed over a year with a tendency downwards in the past year. With regard to the decentralized services, there are 350 patients, and patients who are eligible get access to them only 2 months after they were started on treatment in Carnot, if it is confirmed that they comply with treatment. There are 3 decentralized sites where we have this on offer out of the 28 in the district. So the geographical coverage isn't sufficient in terms of decentralization. On the basis of a number of challenges that we made in the field, we carried out a study with the main objective of describing and understanding the continuum of care for patients living with HIV in Carnot. We are going to show only a section of the outcomes while focusing on description of models of care, the impact on retention, compliance, and perception by patients. The methodology was the following one: retrospective analysis of the program data between 2011 and 2022, a cross-sectional survey with 340 patients of at least 5 years, and there was a genotype resistance test, and a qualitative survey with approximately 90 participants in the active queue, and patients who were not compliant since at least 6 months. Now, towards the end of 2022, the cohort had more than 4,745 patients on treatment, 46% of them in the active queue, and a large proportion were described as lost to follow-up. Here on the chart, you can see the retention in care up to 48 months after the start of treatment, but this shows what happens for the three DSD models. You can see that the likelihood of retention in care goes down over time, and despite the DSD models as of 2016, well, retention hasn't been improved. Now, another indicator, which is the surrogate measurement for compliance with treatment, the majority of patients comply at a level of under 80%, so 20% of appointments are not complied with. Viral suppression and ARV resistance are also indicators of compliance. The results of the cross-sectional survey is an interesting snapshot 3 years after the introduction of Tegravir, a very promising drug that is well tolerated, or whose tolerance is better. 341 people, a majority of women, were randomly selected in the active queue patients. Majority was based on DTG. 27% of patients had a viral load that could be detected, and 12% with a virological failure. When we carried out the resistance test, some 1/3 showed resistance to the category of these two drugs that are used with DTG, and the resistance figures are relatively low, and it shows that the non-suppressed viral load is mainly due to the lack of adherence to treatment. Now, Pascal is going to tell you about the qualitative results.
Thank you, Valentina, and good morning to you all. Now, before I look at the qualitative aspects, I would like to tell you something about the care models which are available in the clinic. As you can see in yellow on the right here, the patients who do not benefit from differentiated care models, including eligible patients who are more than 3 months late, have the conventional classic model of care, and they have to go to the clinic every 3 months to renew their treatment. Now, I'm going to present the perceptions on the differentiated care models and the reported reasons for non-adherence to treatment in order to have an overview of the care experience of those patients. Now, perceptions of differentiated models of care. The plurimensual supply is seen very positively because it reduces the workload of the healthcare professionals and the waiting times for patients. They appreciate the fact that the treatment is available and for free, and many of them said that it was the main reason why they chose the Carnot hospitals to be taken care of. The CAGs are considered to be the most promising models to support patient retention, but of course they work differently. Some patients are very satisfied and others mention dysfunctions such as disagreements among members, breach of confidentiality, and sometimes ARVs being stolen. This is why the patients sometimes withdraw from the CAGs or won't integrate them. And the healthcare professionals mention management systems which are not systematic and which are not standardized, and that can be a problem. And the feedback on the decentralized is actually mixed. Patients appreciate the fact that ARVs are available, but they are sorry that the other services in the care package are not available, such as treatment for opportunistic diseases and therapeutic education, for which they must go to the Carnot hospital. They also would like a more holistic care that would include essential primary care also. And for the reasons of non-adherence, we used as a proxy people coming late. for their appointment at the clinic. The patients face access barriers due to the distance, for example, to the hospital, the insecurity on the way, and the cost and availability of transportation, which very often prevent them from coming on time to receive care. And as one patient says, some barriers can actually be accumulated, and when the patients go back to the conventional model, these barriers, these obstacles are even increased. In terms of the services in the follow-up clinic, there are several challenges. First of all, a crowd of patients who come without an appointment. This generates too much work for healthcare professionals and waiting times that can go up to several hours for patients. The quality of care is impacted. Several healthcare professionals said that they could not dedicate enough time to helping and supporting patients, and some patients lack knowledge about the care that they receive, biological tests and ARV. And as somebody said, the patients who don't understand the system and what they're supposed to do are patients that we're going to lose because they don't understand how important the treatment is. Then there's also stigma. This is a significant factor for non-adherence or even for losing patients. As indicated in those keywords, you see that the patients report a lot of negative experience, bullying, abuse, or insults, verbal abuse and discrimination because of their status. They are ashamed, they are afraid that their status is going to be revealed, and so it can make them reluctant to come to the hospital or clinic. And this is very often why people won't integrate the CAGs or the decentralized care model. And then you have all context-related factors linked to the living conditions. Sometimes the patients have to go away from where they live in order to make a living. The lack of food supply is also something that all patients report as one of the major difficulties because the treatment actually provokes hunger and has a certain number of side effects. A vast majority of patients also report difficulties in the social environment, a lack of support, and all this has an impact on their physical and mental well-being, and also has a negative impact on their adherence to care and to treatment. Now, in conclusion, this study shows that despite the implementation of differentiated models of care for a few years, the retention indicators and adherence indicators are suboptimal in the cohort. The results also indicate that scaling up the models of care is not appropriate, especially for the CAGs and decentralization. This is a promising system, but it does not totally meet the patient's needs. And also, looking at the challenges that patients are facing, we think that differentiated models of care could help improve their commitment, but those who would benefit the most are excluded because of the eligibility criteria. We have made a certain number of recommendations. For the differentiated models of care, we recommend to improve their implementation in order to reach their full potential. Apparently, for example, with a system for CAGs, we would have a broader care offer in decentralized facilities and scale up the viral load for better clinical follow-up. We would also need to review the eligibility criteria, and also we should develop care strategies that would be more targeted and less punitive for the patients who are non-adherent. And we also recommend developing together community campaigns to fight against social stigma, because this is really a problem, and we would need to collaborate with civil society and patients' associations. We also would like to develop advocacy actions with the Ministry of Health and other partners in order to support a wider scale of implementation for this differentiated approach with a holistic approach of patients' management that should take also into account and take care of their other priority needs. We would like to thank all the participants to the study, our partners at the Ministry of Health and the District of Carnot, our MSF colleagues and Epicentre in CAR and Paris, all the co-investigators and our research team, without whom we would not have been able to carry out this study. And thank you very much for your attention.